This conference will now be recorded.
Welcome everybody. We are going to be talking about Chapter 11, which is correlated to baseline vitals, monitoring devices, and then we'll also be talking about history taking, which is going to tie into our patient assessment chapter, and then also our scene size of chapter as well, which we'll be talking about in Chapter 12 and Chapter 13. So first off, our objectives for this lecture, we're going to be going over baseline vitals, what we're going to be utilizing in order to try and see what's going on inside the patient's body. Also looking at different monitoring devices, tools for us to utilize for taking baseline vitals and also getting our patient assessment and general impression. Talk about history taking, and then we will be able to practice this once we meet on Thursday for our lab session. So first, the baseline vitals that we should be utilizing for every patient that we come into contact with is our respiratory rate, pulse rate, skin condition, pupils, blood pressure, pulse oximetry, and then also, depending on our patients, blood glucose value should also be correlated into that, and then lung sounds as well, utilizing that stethoscope. So we can see with this slide, this is going to be our normal vital signs that we see, and it's going to be broken down per age group. So we notice that with the younger generation, their heart rate's going to be higher, respiratory rate is going to be higher, and then their blood pressure is going to be lower. So the rationale behind this is the amount of blood volume that's actually circulating through the system is going to be less for the newborn to 10-year-old. As a result, that heart rate has got to be higher in order to push that blood volume around. Same thing with our respiratory rate. They're going to have a lower oxygen concentration compared to the adult patient. As a result of that, their respiratory rate is going to be increased in comparison to the adult patient. And then with the blood pressure, we can see that it starts low with our newborn and then also grows higher. The reason this occurs is because of the systemic vascular resistance. It is not developed with that newborn phase, and it gets developed over time until that adult patient, in which we should see a normal blood pressure of 120/80 for our adults. So the tools that we have in our EMS bags, our first in bags, in order to help obtain these vital signs. First, we're going to have our blood pressure cuff. So these blood pressure cuffs come in a variety of different makes and models, and then also a variety of different sizes as well. So we should have blood pressure cuffs that correlate to our infant patient, all the way up to our large adult patient, and even our thigh blood pressure cuffs that we can utilize as well. Next, we have our stethoscope. So this is going to help us obtain our breath sounds, lung sounds, and then also obtaining that blood pressure as well. Wristwatch or any other type of timing device so that we can correlate our vital signs and get that proper rate. So when we are taking vitals, whether it's heart rate or respiratory rate, what we're going to do is obtain that pulse or look to see that respiratory rate. We are going to count that up by 30. So once we get to 30 seconds, we're going to take whatever number we came across, and then we're just going to multiply that by 2. So if I am checking somebody's heart rate, I got my wristwatch on, I'm timing it, I count 40 heart beats. Once I reach 30 seconds, then I'm just going to take that 40, multiply it by 2, and so I'm going to have my heart rate of 80. So that's 80 beats per minute. Next, pen light. Pen lights are going to be able to examine pupils, and then we can also utilize this as far as our examination to both physical and mental. Trauma shears, again, come in a variety of different makes and models. So some are going to be our generic trauma shears. And then you can also purchase high-end trauma shears as well, as far as cutting through a significant amount of clothing, such as your leathers for your patients who go on motorcycles and snowmobiles and what have you. And then also our documentation pieces, whether it's a pen and a notebook or some services like to carry around the MinStar forms as well. So here we can see blood pressure cuff. This is going to be our normal adult size. On a lot of these blood pressure cuffs, they're going to have either a right or a left artery indication, and that is where you're going to place that blood pressure cuff on that patient's arm in order to obtain it. You can also see in this picture a stethoscope. So with those stethoscopes, they do have an angle to them as far as the earbud pieces. That angle should always go towards your nose when you are placing that stethoscope on. Depending on the stethoscope, there is a 2-bell system with most of them. So make sure that when you go to obtain that blood pressure or obtain that respiratory rate, that proper bell is in position. So you can simply put your stethoscope on and then tap it to make sure that that proper bell is activated. Now, if you don't hear anything, you just have to turn that bell until it clicks, and then that should select your proper bell setting for it. Here, pen light depicted on the side of these pen lights is going to be different size pupils. So this is going to help you with your patient assessment and then also your documentation. In order to activate the light, you just click the little shoulder piece on there. By depressing that, that's where you're going to actually see your pen light. Now with most of these pen lights, you can't swap out the batteries or anything. So once they go dead, then they're garbage. Trauma shears. So first, let's look at getting our baseline vitals as far as our respiratory rate goes. So first thing that we're correlating is we're going to go through our ABCs, determine that that patient's got a patent airway and is breathing, and then we can start looking at our proper vital signs. So first, rate. Normal adult value for an adult patient is going to be in between 12 to 20 breaths per minute. Then we're looking at quality. So quality, we're depicting whether that patient is getting an adequate amount of volume of air inside their lungs. So we should see proper chest rise with this, and then we should also not hear any abnormal breath sounds as well. Then with our rhythm of our respiratory rate, it should be regular, good intervals in between those breaths. And again, we're looking for that good quality when we're also depicting that rhythm application. With our volume, the normal adult tidal volume is going to be in between 400 to 600 milliliters of air. So with that volume of air, we're going to get enough volume into the lower bronchioles. And as a result, we're going to see that good gas exchange in the alveoli where we got oxygen coming into the system, and then we have carbon dioxide going out of the system. So oftentimes with rate, this is going to correlate in the volume. So if somebody's respiratory rate is extremely high, they're breathing at 30, 40 times per minute, that volume is going to drop significantly because they're not able to get that adequate amount of tidal volume into their lungs when they are breathing that fast. Next, we're looking at heart rate. So our pulse, there's a bunch of different areas on the patient's body that we can actually obtain a pulse. Again, just like our respiratory system, we're looking for rate. So normal adult value for our heart rate is going to be in between 60 and 100. Rhythm, again, we want to see that good rhythm where it's a regular interval in between those two heartbeats. Then we're looking at quality. So it should be a strong pulse. We should have no issues finding it. And when we are checking a pulse too, we can also be looking for skin condition for that patient. So the different areas that we can actually find a pulse, carotid artery is going to be on either side of the neck in that groove in between the trachea, then also that muscle mass. So this is going to be classified as a central pulse. When we are finding these pulses, we can correlate where we find these pulses to an estimation of that blood pressure. So if I feel a good carotid artery, chances are that systolic blood pressure is going to be over 60. Next, femoral artery. This is going to be in the crease between the lower abdomen and the upper thigh. Again, this is classified as a central pulse. So if we are feeling this, systolic blood pressure most likely is going to be over 60 or over 70. Now, this doesn't work in every case, but this does give you kind of a rough estimate of what is going on as far as blood pressure goes. Next is going to be our radial artery. So this is going to be proximal to the thumb on the palmar surface of the wrist. So if we're able to feel that, chances are our systolic blood pressure is going to be above 90. Next, we have the brachial artery. So this is going to be on the medial side of that patient's arm, between the shoulder and the elbow, between the bicep and the tricep. So oftentimes you're going to have to move that muscle mass of that bicep over a little bit in order to actually depict that heart rate utilizing the brachial artery. Now, we don't use this very often for our adult patients, but for our infants and our small pediatric patients, this should be our go-to pulse check. Now, again, the brachial is associated with our central pulses, so systolic blood pressure should be around 70 when we are feeling something like this. Then a couple of pulses that we don't check, or a couple of artery locations that we don't check very often. One is going to be the crease behind the knee. Then we also have the posterior tibial artery. So this is going to be behind that ankle bone. Lastly, we have the dorsal pedis artery. So this is going to be at top of the foot and the great toe side. So all these pulse checks are going to be what's called peripheral pulses or radial pulses. And so usually our systolic blood pressure is going to be right around 90. So here we can see the carotid artery. So all of these pulse checks, what we're looking for is the artery or the vein that's closest to the skin. That's why we can find them so easily in comparison to the rest of the patient's body. So this is going to be a good tool to utilize when we're dealing with environmental issues, such as a patient being too hot or too cold. We can put hot packs or cold packs in these locations of the body in order to cool that patient's blood volume down so that it circulates through the body, and then we can actually use it as a system-wide cooling or warming effect. Next, we have that femoral artery. So we're going to compress that blood vessel against the pubis area of the pelvic bone in order to actually depict that heart rate for that patient. Radial, this is going to be kind of our go-to whenever we have some type of conscious patient. Again, the systolic blood pressure is going to be right around 90 if we can feel that. And at the same time, we're going to be checking that patient's skin condition as well. Next, we have the brachial artery. So again, moving that bicep, that muscle mass out of the way a little bit in order to actually get that brachial artery. And then the pulse checks that we don't actually utilize very often. This is more widely used in the emergency room setting or by orthopedic docs where they're doing a more thorough assessment on a specific body part depicting, what type of circulation is actually going through that patient's lower extremities. The one that we're going to commonly use is when we are assessing CMS checks. We should be utilizing that dorsal pedal pulse. So when we're depicting pulse quality and rhythm, when we have a strong pulse, when we document that and find that, this means that we have a proper blood volume that's actually going through those blood vessels. So they should be full and strong. When we're trying to find that pulse and it's weak, difficult to find, or if we classify it as thready, this is going to correlate to our weaker pulses. So again, there's not a sufficient amount of blood volume that's actually going through that blood vessel at that time, and that's why it makes it difficult to actually find that pulse. So with regular rhythm, irregular rhythm, self-explanatory, again, we're looking for that regular rhythm when we are doing a pulse check. When we feel an irregular rhythm, oftentimes this is correlated to are patients who suffer from AFib or a different type of cardiac dysrhythmia where that power plant inside the heart isn't firing properly. So next, we're moving on to skin condition. So when we walk into the room and we're forming our general impression, one thing that we can often see right off the bat is going to be that patient's skin color. So what we're looking for is a patient who's healthy and circulating that blood volume properly. They're going to be pink, warm, and dry. But we're going to be talking about some of the abnormal findings that we could see. So first, if we walk into the room and we see that patient, they're depicting paleness or pallor, this is going to be extreme vasoconstriction, oftentimes associated with blood loss, whether it's internal or external. This could indicate shock. Patient could be pale, cool, clammy skin. This could either be an early indication of hypoxia, hypoxemia, or hypovolemia. Next, we come across our patient and they have blue-gray color or cyanosis. This is an indication of an inadequate oxygenation or poor perfusion. Usually this is going to appear around the mouth and the fingertips because that is going to be where our smallest blood vessels are, and that loss of oxygen is going to show with that cyanosis color. Again, if we see cyanosis on our patients, this should be an automatic indication that this patient needs some type of airway treatment and then also some type of oxygenation treatment. Next, we approach our patient and they have either a red color or flushing. So this could be a couple of different things. Heat exposure is one, where the body's trying to give off that excess heat, and that's why we can see that flushed skin. You could also see it peripheral vasodilation. So we could see this with some type of spinal injury, and they're suffering from spinal shock, or a patient who's got some type of predisposition disease such as rosacea too. Lastly, we could see this with carbon monoxide poisoning. Oftentimes when we have a patient who has carbon monoxide poisoning, they're going to have those beet red cherry cheeks, kind of like Santa Claus, and that's an indication of that carbon monoxide actually binding to that hemoglobin. Lastly, we could see modeling of that skin, which is going to be a blotchy pattern. This is similar to cyanosis, but oftentimes we don't see the bluish color associated with this. Now, this is a sign of shock, or it could be a sign of blood pooling as well. So here, we see this patient, pretty pale, depicting that pallor. Next, this is what cyanosis is going to look like. So we can see that on the finger beds. We can see that around the lips. Again, this is a sign of a lack of oxygenation. So these patients are going to need some type of oxygen therapy in order to start getting a higher level of oxygen content inside that system. Next, we see this patient. This patient actually suffers from rosacea. So we can see the red flushing color of that skin. This looks very similar to the patients who suffer from some type of heat exposure and then also carbon monoxide poisoning as well. And then this is going to be the modeling. So we can see that vasoconstriction of that patient's blood vessels. They're not adequately perfused into that skin. As a result, we're losing that blood volume. And then also keep in mind how much body heat that we're losing as well. So when a patient starts to show those signs and symptoms of shock, they're shunting that blood away from their extremities and also their skin. And as a result, we're losing a significant amount of body heat from that skin condition. So with skin temperature, when we feel that patient's skin and they have hot skin, oftentimes this is going to be associated with a fever or an exposure to heat. So with fever, the reason why patients who get sick will have a fever is because this is a naturally occurring defense mechanism inside the body. So if I get a bacterial infection or a viral infection, my body's going to see that and it's going to increase its body temperature. And with that increased body temperature, oftentimes I can kill a lot of that bacteria or that viral infection. Now that's why we're seeing changes in modern medicine, where when we were kids and we were sick, we automatically got Tylenol or some type of medication that would bring our body temperature down. Now, with lower grade fevers, so usually about 101 degrees and lower, pediatricians and doctors will oftentimes recommend not giving somebody any type of medicine that will actually drop their body temperature, because the defense mechanism inside the body is actually doing its job for us. Next, we have cool skin. So this is going to be inadequate circulation, could be shock, or it also could be an exposure to cold weather conditions. So when we're dealing with this patient, stick to your basics and work your way up. Try and get them warm, cover them with a blanket, especially the patients in shock. There is a lot going on inside the patient's body when they are suffering from shock. And a great way as EMS providers for us to help that patient is to simply keep them warm at that time. Now, if a patient's skin condition is cold, this is going to be correlating to an exposure to cold. So we don't have to touch too great in detail for this with our geographical area, but when a patient does have cold skin, we want to handle them basically with kid gloves. Because if a patient is severe hypothermic and they have cold skin, what's going on underneath the skin is there's actually ice crystals that builds up inside the tissue. So if we jostle them around, we can either break those ice crystals and actually cause tissue damage. And then also by doing that, we can send that patient into a cardiac dysrhythmia and send that patient into cardiac arrest. Moving on to skin condition. If a patient has clammy skin, this is correlated to wet or moist, and this is a result of hypoperfusion. So we're not getting that adequate amount of circulation in that skin condition. Diaphoresis is correlated to profuse sweating. So this could be from a low blood sugar event, a patient who is suffering from a cardiac issue or a respiratory issue. Next, we can also check the capillary refill time. So we're going to pick a point on that patient's body that's radial away from them. So we can use the finger beds, we can use the toes, use the feet or the hands. We're going to compress on that skin. It's going to show a different color. And then hopefully within about 2 seconds, that skin condition should go back to normal. So that's what we're utilizing as far as cap refill time. Now, this is a great assessment tool to use for our pediatrics and infants, but oftentimes for our adult patients, this isn't a very reliable indicator, especially in our geographical area. Some things that can hinder that is cold weather. So our body shunting our blood to our more core body position in order to keep that body warm. So that can throw off our capillary refill time. And then also tobacco and alcohol use too can delay that capillary refill time. Next, we're looking at pupils. So pupils, we can use a mnemonic, which is referred to as Pearl. So what we're going to be looking at is first off size. So when we refer to them as dilated, they're going to be large or larger than normal. And then constricted is going to be small or smaller than normal. There's another size that we can use, and that's going to be pinpoint. So if it's just a very small little dot, oftentimes that's correlated to opioid overdoses. Next, we're looking at inequality. So pupils should be the same size as each other. So if we notice that they are different sizes, this could be either an indication of a severe head trauma. It could be some type of pre-disease where maybe their pupils are always dilated or always different sizes. And then also certain eye drops as well can manipulate those pupils. So when we start diving into a proper patient history and assessment, if we do find any abnormalities with those pupils, we want to make sure and ask that patient if they have any of these things going on. Next, reactivity to light. So try and get that patient into a shadowed area. Utilize your pen light. When you show that pen light into the eye, it should go from a dilation effect to a constricted effect. And this should be simultaneously between both eyes. So if I shine the light in the left eye and it constricts, that right eye should constrict at the same time, even though I'm not putting light into that right eye. So one of the things that can change pupils most often is going to be any type of drug use. So we can see the difference between all those different drugs and the effects that it has on pupils. So oftentimes with uppers, they are going to make those pupils larger or more dilated. Anything that's classified as a downer or a narcotic is either going to constrict those pupils or make them pinpoint at that time. Next, when we have blood pressure, systolic blood pressure is going to be pressure exerted on the walls of the arteries during that contraction and ejection of blood from that left ventricle. So that's going to be our afterload of that patient's blood volume when it is leaving that patient's heart. Our diastolic blood pressure is going to be the amount of pressure on the artery walls while the ventricle is at rest and not contracting. So it's kind of like our preload with that blood volume coming back into the system. We can also check that orthostatic blood pressure. So we're going to be checking the blood pressure with the patient when they're in a supine position, a sitting position, and then also a standing position. So each time that blood pressure should change a little bit. And again, we are going to practice this once we meet for our lab session. So how we check a blood pressure? First and best thing that we can do is do it manually with auscultation. So I'm going to attach my blood pressure cuff. I'm going to get my stethoscope ready. I'm going to find my pulse point, which is going to be right around my AC. And I'm going to increase my blood pressure cuff until I start hearing that heart rate. I'm going to increase it by another 30 until I can't hear it anymore. And I'm slowly going to relieve that pressure from that blood pressure cuff. Once they start hearing that heart rate again, that's going to be my systolic blood pressure. I'm going to keep letting go of that pressure, and that noise of that heart is going to begin to deteriorate. And once I stop hearing it, that is going to be my diastolic blood pressure. Now, in some environments where it's very difficult to hear or obtain that blood pressure via auscultation, I can also use the palpation method. So the only negative behind this is it's not the most accurate, and I'm only able to get this systolic blood pressure. So I'm going to feel that patient's radial heart rate. I'm going to put my blood pressure cuff on. I'm going to increase it until I can no longer feel that radial pulse, increase it by another 30. Then I'm going to slowly let go of that pressure with that blood pressure cuff. And as soon as I start feeling that radial pulse again, that is going to be my systolic blood pressure. So how I document that is it's going to be, let's say the patient's systolic blood pressure is 122. I would write 122 over P or 122 by palpation. So other monitoring equipment that we can see, pulse oximeter, non-invasive blood pressure monitoring, and then also utilizing a cardiac monitor. So with the pulse oximeter, our desired ratio is going to be 94 to 99%. Once we attach that pulse oximeter to a patient's finger, that's what it's doing. It's using an infrared system that's looking at the capillary beds. Depending on your pulse oximeter, if it's a basic one that's just measuring heart rate and pulse oximetry, it can give you a false reading. Because what it's doing is it's just looking for the amount or percentage of hemoglobin that are actually carrying a molecule. So if a patient is suffering from carbon monoxide poisoning, it will give you a false reading of 100% because their body binds to carbon monoxide much more readily than it does oxygen. So it can give you that false reading. Also, patient who is hypoperfusing, so they have signs of shock. If they have an environmental condition such as hypothermia, sometimes you're not going to be able to get the best pulse ox reading. Keep in mind too, we shouldn't be utilizing our pulse ox in order to obtain that proper heart rate. We should still be feeling for a pulse and checking a proper pulse. especially for patients who have an irregular heart rhythm. Oftentimes it will give us a false reading when we are utilizing that. That's what our pulse ox is going to look like. So a finger probe is going to show us the oxygen saturation, which is shown on the left. So that's 96% of our hemoglobin are carrying some type of molecule. And then it is also going to show the heart rate. For non-invasive blood pressure monitoring, so this is going to be our automatic blood pressure cuffs. So we can see these on cardiac monitors. Usually this is going to be used by advanced level support transport services. So once Gold Cross arrives on scene, they're going to be able to bring out their cardiac monitor, and they can actually utilize this tool to measure a bunch of different signs and symptoms. So our heart rate, they can put a 4-lead on and actually look at the electrical rhythm. They can use an automatic blood pressure cuff, and they can also utilize end-tidal CO2, which is going to be the amount of carbon dioxide which is in the exhaled air from that patient. Ideal end-tidal CO2 range is going to be in between 35 and 45. So now we're going to be talking about patient history and then also gaining control of that scene so that you can do your proper patient assessment and gather all of the information that you need. So once you've determined that that scene is safe and you enter that scene, you have to bring order to that environment. Now, the common denominator between any type of 911 call that was made is going to be the fact that whoever's on scene has lost control, and that's why they have to call 911 and bring somebody in order to gain control of that scene. So for us as EMS providers, we got to bring order to that environment. Next, once you find your patient, introduce yourself to that patient, introduce yourself to any family members around. Gain patient consent. So you can introduce yourself and also your certification level, and then you're going to ask that patient if you can assist them. Oftentimes when that 911 call is made, it's either made for a patient who's unresponsive or made by that patient themselves. With that 911 activation system, oftentimes we'll have implied consent at that point. But oftentimes we'll show up on scene and a family member called 911. That family or specific patient doesn't really want to be assessed. That's where you actually have to ask them, my name is Corey, I'm an EMT. Can I ask you a few questions or do a medical assessment? When that patient says yes, then that's going to be that express consent within our legal implications. Next, position yourself. Keep in mind if there's any type of scene safety consideration, position yourself far enough away from the patient that's so you don't get struck, and also that you have an exit plan. Use your proper communication skills. So this would be a good chapter to review going back. Be courteous to that patient, and also be calm. So by being calm, that really brings an element of calmness over the entire scene. So the family members and the patients will oftentimes kind of shadow whatever emotion that you're displaying at that point. Then use touch when appropriate, and then keep in mind utilizing your resources too. So if you have a female patient and they have a chief complaint in a specific anatomical location that might be uncomfortable for them, you have a female partner there, maybe you should utilize that female partner actually doing the physical assessment on that patient, and then vice versa too. You can always ask your patients who they feel more comfortable with, whether it's a male patient caregiver or a female patient caregiver. So next we're going to start diving into the history taking. So we're finding out exactly why that patient called 911 or why that family member called 911. So the chief complaint that that patient is going to give you is going to be the reason why that EMS crew was called to the scene. Oftentimes a patient will have multiple complaints, but the chief complaint is the one that they're suffering from the most, or the one that 911 was actually activated for. Next, with our demographic information, so this is going to be correlated into our documentation. date, time, and any type of identifying data. So remember, we have that minimum data set that has to be included within any type of documentation and recording. Next, we're going to dive into current health status, so any type of medications that they're on, allergies to medications or environmental factors, whether they have alcohol and drug use during the day, diet, screening tests, and any type of environmental hazards. So we're looking at the sample history, and we're going to be using this mnemonic in order to do a good and thorough patient assessment. Now, basically what I'm giving you here is the base of operations as far as doing a patient assessment. Now, over time, you guys are going to be able to kind of pick and choose how you want to conduct that patient assessment, as long as you're getting all that relevant information. So when we're breaking apart the sample, the S is going to stand for signs and symptoms. So signs are going to be any objective or physical evidence of that medical and trauma condition that either you can see, feel, or smell. Symptoms are going to be from what the patient actually tells you. So if a patient says, I've been having abdominal pain for the last 3 days, that is going to be a symptom. Now, if you palpate their abdomen and you see distension in the lower right quadrant, that would be a sign from that. So again, S is going to stand for signs and symptoms. Now our A is going to stand for allergies. So does that patient have any allergies? Again, whether it's medication related, environmental related, food related. Next, medications. So medications that they're currently taking, and depending on our patients, this can be an extremely long list. So we don't have to get every single medication that they're on. If it's one of those patients that has a giant toolbox full of medications, but maybe you want to focus specifically on the medications in correlation to what their complaint is. So if we show up on scene, patients complaining of chest pain, again, they have that giant drawer full of medications. Maybe you want to find out what medications are specifically in relation to that patient's cardiac health. Any type of pertinent past history. So again, our patient who's experiencing chest pain, do they have a cardiac history? Have they ever had that feeling before? L is going to be our last oral intake, and then E is going to be our events leading up to that injury and or illness. So that's what our mnemonic looks like for our sample history. Now, when we're diving deeper into our signs and symptoms, we can use the OPQRST mnemonic or model in order to get all the relevant information that we need for their signs and symptoms. So O is going to stand for onset. So when and how did these symptoms begin? P is going to be our provocation. So it makes the symptoms worse. What makes the symptoms better? Quality. So have that patient describe that pain or that symptom. So keep in mind, not every patient is going to be experiencing pain at that level. So if they are not experiencing pain, don't ask them to describe the pain, because then you're going to get poor history taking. So if they're having difficulty breathing, having them describe that difficulty breathing. R is going to be our radiation. So does that feeling or that pain or whatever their complaint is go anywhere else? So patient complaining of chest pain, oftentimes they can have radiation to either their jaw or their left arm or even their back. Next is going to be severity. So that patient is going to rate their pain or that symptom on a 1 to 10 scale, 1 being no pain or 1 being no difficulty breathing, 10 being the worst pain possible or the most difficulty breathing that they've had. And then time could be how long that they've had that symptom. Now we can see that this correlates to our onset. So we can also ask them, does that sign or symptom or that pain come and go, or does it stay consistent? Now, special challenges that we're going to face on almost every call in some capacity. Silence. So some patients, maybe our pediatric patients who have a history of patient abuse might be silent. They don't want to answer your questions. Or depending on our cultural instances within our service area, certain cultures don't allow a male patient to talk to a female patient if it's not their husband. So you would have to actually do your patient history taking through the husband and then through your patient. Next, we can see an overly talkative patient. So when you're trying to gather your pertinent information, they're going to give you every sign and symptom that they've had for the last 4 years. And sometimes you have to reroute them to get them back on track. So you don't want to be rude or mean to them, listen to them, and then just try and redirect them back to the specific chief complaint that they were actually called for the day. Patients with multiple symptoms, especially patients who are displaying multiple signs and symptoms in correlation in 2 different body systems. So basically you have to start breaking apart their signs and symptoms to see what protocol or guideline that you're going to be going down. So a patient who's got difficulty breathing and chest pain, trying to differentiate, is it cardiovascular in nature and that's why that patient is displaying signs of difficulty breathing? Or is it the reverse, where a patient has difficulty breathing and as a result of that low oxygen, they're experiencing some signs of symptoms of chest pain? Next, we have angry patients. So patients who could be under the influence might be angry, or patients who didn't actually call for themselves, but that call was made by a family member or friend. Intoxicated patients, depressed patients, maybe they have ideas of suicide. As a result, they don't really want any help at this point. So they're going to downplay their signs and symptoms so that they can stay at home and then also carry out whatever they might have be going on. Patient who's got an altered level of consciousness or who is completely unresponsive, very difficult to gather history from that patient. If there's family members or bystanders around, you can utilize them as far as getting that patient history. But if nobody's around, then you got to use your physical tools too, looking for any type of ID bracelets or medical cards inside their wallet. Language barriers. So almost every patient in the St. Louis, Douglas, Lake County areas, they're going to be having English as their primary language. But if you were to start working in the Madison area or the Minneapolis, St. Paul area, that's where a lot of patients have a variety of different languages. Next, we could have vulnerable adults. So again, it's very difficult to actually get a proper history from them. So utilize staff members on scene to try and gather additional information. Hearing impairment, and then also friends and family. Friends and family can pose a huge issue when you're trying to do a proper assessment because they might be chiming in with every question. So what you can do is take your partner or take another rescue squad member, assign them to the family member and kind of separate them a little bit so that your partner's getting the history from the family members while you're gathering history from the specific patient. So that ends our lecture for baseline vitals, monitoring devices, and history taken. Next, we're going to be talking about our scene size up and scene safety considerations. Thanks, guys.